As Mr. Barton told us earlier, we know young adults in Texas are responsible for or involved in more impaired driving crashes than any other group. But as uh, we also know that they are not the only ones who get behind the wheel when they've been drinking. Next, we'll hear from Jake Nelson, who heads up AAA's Traffic Safety Advocacy and Research Division. Jake is an epidemiologist who brings a scientific mind to analyzing statistics as the basis of effective ways to keep drivers safe. For the past 5 years, AAA has conducted research to better understand the culture of traffic safety in America and to document the prevailing views and perceptions people have about impaired driving. Jake is here to put a face on today's drunk driver and share highlights from AAA's recently completed Traffic Safety Culture Report. Jake Nelson.
Thanks. Feel like I'm on The Price is Right. Come on down. Good morning. So I am based in Northern Virginia, and people in Northern Virginia, is anyone here from Northern Virginia? All right, so wouldn't you agree people in Northern Virginia think they're Southern, but they're really not? So it's nice to be here. I actually get made fun of. I don't speak with a Southern accent, but I do use the word y'all, and my friends in Michigan, where I was born and raised, tease me all the time for it. So I can use y'all here and not be made fun of, which is good. Kendall, you mentioned Ebola, which was kind of interesting. So I come from a public health background, and I'm actually an epidemiologist. I'm one of the guys in the white suits, potentially, if I stayed in that field, who would run around trying to figure out what this Ebola thing was and what was causing the disease. And I'm pretty sure that Kim Kardashian has probably destroyed more lives than Ebola so far in the United States. So I agree with you that what we're talking about today is way more important. So I'm from AAA, as was mentioned to all of you. We're a not-for-profit organization. We're actually the largest membership organization in North America, second to what other organization? Who has a guess? AARP. Anyone else? NRA. Why always NRA and AARP? Any other guesses? The Catholic Church. It's kind of an interesting fun fact to AAA. 1 of every 4 households in North America is a AAA member, which is really great. So we have a lot of reach. We represent the motorist. How many of you are AAA members? Excellent. Thank you for your membership. So a little roadmap for today's session. I'm going to talk about alcohol-impaired driving by the numbers just very briefly. You guys have heard a lot of this already, and I'm going to touch on it at a very high level. I want to talk about drug driving a little bit. I actually wasn't asked to talk about this, but I feel like it's really important. And Kendall said impaired is impaired is impaired, and it is so true. In March of this year, AAA took a deep dive into the drug-impaired driving issue to educate ourselves, because we didn't feel like we really had a good handle on the issue. And so we heard from a variety of experts from around the country and became a little bit smarter on the topic. And if there's one thing we took away from that summit, it was that we cannot address impaired driving by only addressing alcohol. And we can't address drug-impaired driving separately from alcohol-impaired driving. They often happen together, and we have to address them together and think about them both when addressing the substance-impaired driving problem. So I'm going to talk about that just briefly. And then I'm going to talk about public attitudes and beliefs on substance-impaired driving. That means alcohol and drugs, and by drugs I mean prescription drugs, over-the-counter drugs, illicit drugs, and I say marijuana separately because depending on where you live, you can't really categorize it in any of those other categories, Washington State and Colorado. So by the numbers, here you have the number of people killed in crashes on the vertical axis and the years on the horizontal axis. And what's really interesting about this picture, and I could have shown the last 3 decades or 4 decades if I had room on the slide, but what's really interesting is that despite the dramatic drop in highway fatalities that have occurred over this period of time, we still have a lot of work to do, which is one interesting fact, but also roughly a third of highway fatalities have remained constant over those 4 decades that involved at least one alcohol-impaired driver. So that really stubborn proportion was actually one of the drivers for the NTSB over the course of 2013 and announcing its recommendations in May of 2014 to take a deep dive into the issue of substance-impaired driving, to try to look at, well, what have we learned over the last few decades, what works, and recognizing the fact that roughly a third of all highway deaths involve at least one impaired driver. What do we need to do differently to address that proportion? Even though the raw number is going down, still we're looking at roughly a third of people who die on our roads involving an alcohol-impaired driver. Of course, they issued a lot of really great recommendations. I'm not going to go through them here, but what's the one that got all the attention? 0.05 got all the attention. There are a lot of really great recommendations that the NTSB offered. So I'd encourage you all, when developing your strategic highway safety plans, to take a look at those. Switching now to the profile of the American drunk driver. So most of you, by nature of the work that you do every day, probably already know what the demographics of the average drunk driver would be. But just humor me for a second. Your neighbor probably has an image in his or her mind of what the average drunk driver is. What are some of the adjectives that your neighbor might use to describe this person? Male. Extremely intoxicated. Any others? Uneducated. Okay, here are some of the stereotypes that I'm getting at. What are some of the others? There you go. Tattooed. See, you guys get where I'm going here. This is what your average person, none of the people here who work in this room on this issue would think that, because we do this every day. We're familiar with what the data tell us, but your neighbor has a very distinct image that is informed by a lot of stereotypes about what the average drunk driver is. So that's what I want to talk about a little bit here today, just briefly. Keep in mind, the data that I'm using and presenting to you paint the picture on a national scale of what your average drunk driver might look like. Now that can be very different regionally and even at the community level, from one community to the next. But nationally speaking, your drunk driver is young. We heard young. In fact, 32% of the folks who are drunk and cause death in a highway crash involving a drunk driver are between the ages of 21 and 24, 30% 25 to 34, and 24% 35 to 44. And of course, that may be different in the state of Texas or in regions of the state, but nationally, this is what we know about the age of your average drunk driver. So if we switch over to whether it's male or female, we know it's usually male, and we heard that already this morning. Using NHTSA data here, about 20% of drunk drivers involved in fatal crashes are male, 7% female. Looking at race and ethnicity, there's a very, very strong relationship between being non-Hispanic white and all of the other races and ethnicities here. In fact, 23% of the drunk drivers involved in fatal crashes are non-Hispanic white, and then there's a distant 15% are American Indian and Alaskan Native, and then 14, 13, and 10% down the line. So far we have young, white, male people as your average American drunk driver. So we talked a little bit just a moment ago about what some of the stereotypes are, the really common stereotypes that our neighbors might think. But my point here is that it's easy to think that the average drunk driver is never going to be us. It's never going to be our kid. It's never going to be someone we know well, a friend or family member, when in fact, this is your average American drunk driver. And my point here isn't to make fun of Michael. I actually went to school with him at the University of Michigan. He's actually a really good guy, but sometimes people make really poor choices. And my point here is that your average American drunk driver is somebody who looks like all of us and can be our kid, can be our neighbor, good people that make really poor choices. So let's talk about drugs for a minute. So major, major public health challenge, especially marijuana. That's what the hot topic is right now. I would argue, though, that there's probably another really big and growing problem in the drug-impaired driving sphere that no one's really going to consider very seriously for a long time. And that is older drivers who take prescription medications. And that's going to be a problem that grows and grows and grows until it slaps us in the face, and then we're going to have summits to try to figure out what to do about that if we don't start working on it today. But in terms of the national scope of the problem, we are still learning a lot about this. The data that we have on drug-impaired driving is terrible, absolutely terrible. But what we have tells us that roughly 14% of nighttime drivers and 11% of daytime drivers test positive for one or more drugs. All right, if we look at both oral and blood test results, we see that 16% of nighttime drivers test positive for one or more drugs. The most common, marijuana, followed by cocaine, followed by methamphetamine. So, want to just flag something for you. The issue of alcohol and drugs, and I mentioned this at my opening, that these things often happen together. We cannot address them separately. We need to work on them both at the same time. Even if you don't think or believe that drug-impaired driving is a big deal, if you look at just the percent of alcohol-impaired cases where there was some other drug, usually marijuana, in the data that we do have, was also on board, what the synergistic effects of those substances could do to the driver and the risk that they pose to themselves and to other people. So we need to deal with those together. And marijuana is the one that we know the most about, which is scary because we actually know very little about that one. I'm going to talk about that in just a moment. So these are just some of the challenges that we face when we look at marijuana in particular. And how many of you are drug recognition experts in the room again? Raise your hand for me. How many law enforcement officers have been through A-RIDE training in the room? Okay, so you all know this. But these are all some of the problems that we have with marijuana in particular, the one that's popular right now. So recreational versus medicinal use, chronic versus occasional use, presence versus impairment is probably the most controversial issue. At least it is at AAA. It's one of the policy issues we struggle with a lot. Is we're a traffic safety advocacy organization, and law enforcement has a duty to address this from a crime perspective, also a public safety perspective. We're charged with the public safety side of it at AAA. And just the presence of a drug, marijuana is a good example of that because metabolites can remain in your body for a long time, but just the presence of that drug doesn't necessarily mean you're impaired by that drug. So that makes prosecuting these cases really challenging. And it also affects and impacts justification for zero tolerance per se limits on marijuana in particular. And that's true for other drugs as well, especially drugs that we don't know a lot about, a lot of prescriptive drugs or medications. Duration of impairment and the concentration of THC and how that relates to crash risk and the severity of crashes. All of these things address and affect what is called the dose-response curve. We're very familiar with what that curve is for alcohol, all right? It's the curve that shows that at various concentrations of alcohol in your blood, what your crash risk is as a driver. We don't really have a firm understanding of that for drugs. And even if we did, that curve would be very different for every different drug. So we have a lot of work to do to be able to talk about per se limits. And in the states that have set those, so I'm thinking of Washington State and Colorado, for example, 5 nanograms per deciliter of blood is completely meaningless. There's absolutely not one shred of evidence to suggest that 5 nanograms per deciliter of blood of active THC in the blood means anything specific about crash risk. Because that will be different for everybody based on all of these things. So we're in a situation here where we're way ahead in terms of public policy than we are with research. And we heard Georgia talk about the importance of evidence-based countermeasures, things that we know work because we've researched them and we've been able to show the effect that they have. We don't really know that. We're definitely putting the cart in front of the horse here on the issue of drug driving, marijuana in particular. So it's one of the reasons why at AAA we've committed to doing some research in this area. I know NHTSA has done a lot of work in this area as well and continues to do it. We have 2 studies that are in progress right now at our AAA Research Foundation for Traffic Safety. One at a variety of states, one in Washington State. We're going to look at a couple things here. One, has the incidence of cannabis-involved driving increased pre to post legalization? So just how has legalization of marijuana in those states affected marijuana-involved crashes? We also want to know what the relationship is between the presence, blood concentration of THC, and crash severity. And this is all helping to try to get us to move the needle a little bit, to try to understand a little bit better whether we can even have a meaningful conversation about a per se limit for marijuana in particular. So this isn't going, these studies aren't going to answer those questions definitively, but we're hoping to move the needle a little bit and contribute to that body of knowledge. We also have a study that we're considering for approval this January that would look at steps that we can take across the nation to improve the data that we collect and have available to us to understand the true magnitude and scope of the drug-impaired driving problem in the United States. This is really important, not only to understand how big of a deal this is, but also if we're gonna try policy approaches or a variety of different interventions to try to address it, we have to be able to measure progress. All right, so that's step one. And so one of the studies that we're hoping to initiate in January is to help make some recommendations and to pursue that at the state level and at the federal level in terms of funding for states who enact those changes to improve data quality and the amount of data that we can collect on drug-impaired driving. And that has a lot to do with toxicology lab procedures and seeking a little bit of standardization there in terms of the tests that are used in toxicology labs and also the panel of drugs included when a law enforcement officer sends a blood sample for testing. A really complicated issue I want to talk about is the prescriptive medication issue again. So obviously this can be illegal in that people who don't have a prescription for a drug use it anyway. People who have a prescription for a medication can use it illegally by abusing it. But there's also a huge segment of the population that is just following the doctor's orders and taking the medications that they need to treat the medical conditions that they're dealing with and don't know that they're putting themselves and others at risk by getting behind the wheel. So I think on the slide I have Roadwise RX here, and there's a URL you can go to there to use this tool. It's free to use. You don't have to be a AAA member to use it. But how many people here have heard the term brown bag before? Brown bagging. So this is what a gerontologist or a primary care physician who works a lot with older adults might use. And what it means is, hey, Mrs. Smith, at your next appointment, I want you to take all the medications that you take, prescriptive and over-the-counter, any supplements that you take, put them in a bag, bring them in, and at your next appointment, we're gonna sit down and we're gonna go through all the bottles. We're gonna look for drug interactions. We're gonna look at whether you even need some of these medications anymore. We live in a world of specialists now, right? So we may have 4, 5, 6 different doctors treating one patient, especially in older ages, whereas 30 years ago, we had our primary care physician do this for us. And so physicians may not realize what other medications have been prescribed to their patient. So Roadwise RX is basically a virtual brown bag exercise. You can go there, you can choose from a drop-down menu all the medications that you take over the counter or prescribed and submit it. It will produce a report for you that flags all of the side effects of the drugs that affect driving performance. It'll also flag interactions between the drugs that you submit and interactions that may exist between drugs that you submitted and food and beverages that you may consume that could affect your ability to drive, all right? It provides very specific information to you about how these side effects or interactions between medications can affect your performance behind the wheel. And the utility of this is you have a printout, which you can do a couple things with. You can put it in your glove compartment or carry it on your person in case you are injured in a crash. So how many have heard of yellow dot programs before? All right, so this is a really great tool if you live in a state where there's a yellow dot program. First responders know to go to the glove compartment to get medical information about you, including the medications that you're taking, so that could be helpful. You can also take this to your pharmacist or to your healthcare provider and have a conversation about the results. And the good news is there are a lot of things that your healthcare provider can do to help mitigate some of the risks. It can change the medications that are prescribed to you, can change the dosing of those medications and also the timing of the dose that you're prescribed so that it affects your ability to drive less. So I had mentioned a high-risk group, older adults. The AAA Foundation did a study a few years back, I think published in 2008, that looked at people 65 and older and asked them questions about driving and medication use and their general wellness. And we learned that a lot of folks in that age bracket are taking sometimes multiple medications that could cause a risk for them as drivers. But what is probably most alarming is that about half of the people that we surveyed nationally had never been talked to by their healthcare provider about the medications that they take and how it could affect their performance behind the wheel. Half. And think about how rapidly the age group 65 and older is growing in the United States. Half of them are not being talked to about their medications and driving. So this is a huge, growing, and I would say silent issue that we should start paying more attention to. So we're really painting the plane here as we fly it when we talk about drug driving, and that's kind of scary to me. We don't have answers yet, but we need to start thinking about what those might be. I'm not recommending that these are things necessarily that we need to do, because I tried to also acknowledge real world implications of these efforts. So we could test everyone arrested or convicted or who's injured in a DUI, DWI, or DUID crash. But there are obviously cost and training, time, and lab capacity issues there. But doing those things would help provide us a lot more information about drug driving, the true magnitude and scope. Drug driving per se laws and DUID. I talked about that a little bit, sort of the contrasting responsibilities of law enforcement for the crime aspects of drug driving, but also there's the public safety aspects of it, and the whole presence versus impairment conundrum there that affects this issue for us in a challenging way. And then also there's public attitudes and beliefs around this issue. And so for commercial drivers, we have a different standard for them in terms of how much impairment we're willing to accept. So, and I'm not surprised by that. Somebody who flies a commercial plane, somebody who drives a large truck, all right, has different laws or rules that apply to them. But we as a society are willing to accept much more risk and impairment from all of us. And that's because, as you'll see in a minute, it's never us, it's always the other guy. Well, I can manage my marijuana and drive. I actually drive slower. I'm more cautious. But it's those other guys who get high and drive that we should all be concerned about. So we can't all be above average. And that's the problem with public attitudes and beliefs. So we're going to shift gears now. I'm going to talk a little bit about the AAA Foundation's Traffic Safety Culture Index. So this is a nationally representative sample. It's done online. Only U.S. residents, people 16 years and older who are active drivers. And this survey includes over 3,000 people. So we look at a variety of issues in this survey, not just substance impaired driving. We look at distracted driving, graduated driver's licensing issues, a whole range of things. But substance impaired driving is one of the issues that we look at, both alcohol impaired and drug impaired. So I'm going to provide some statistics here for you on in both areas. So on the alcohol impaired driving side, we know 96% of American drivers believe it is somewhat or completely unacceptable for somebody to drive when they think they may have had too much to drink. 93% of drivers think that people driving after drinking alcohol pose a somewhat or very serious threat to personal safety. And here's the catch, that 1 in 5 of those same drivers who report they consume alcohol admit to doing it themselves at least once in the past year, and 15% do it multiple times a year. So the punchline here, do as I say, not as I do. It's always the other guy, it's never me. I just don't want all of you to do it. I can manage it well. Obviously, we know that that's not true. So on the drug-impaired driving side, what's interesting here is there's somewhat less concern about drug-impaired driving than drunk driving. So for example, compared with 71% of drivers who said people driving after drinking pose a very serious threat to safety, only 61% of people driving after using illegal drugs posed a very serious threat, and 32% said the same thing about people driving after using prescription drugs. So among drivers who report using marijuana, more than a third, or 36%, said they drove within 1 hour of using marijuana, at least once in the past year. Fewer than 3 in 5 drivers think that driving within an hour of using marijuana increases crash risk at all and nearly 1/3 said they don't even know how marijuana affects their ability to drive. So we have a lot of education. I think even at AAA, we've decided one of the takeaways from our summit was that we have a lot of education internally to do of the public affairs people who work at our clubs all around the country on this issue, so that we can speak more intelligently about it to our members, to media, and to state policymakers. Help raise the bar a little bit on what we ought to all know as highway safety professionals and policymakers. So one thing that we also surveyed in the Traffic Safety Culture Index is to try to understand a little bit about attitudes and beliefs around countermeasures that affect substance impaired driving, both alcohol and drug impaired driving. So some of those results I'm gonna list for you here. 68% support requiring all new cars to have basically built-in alcohol ignition interlock technology, make the car the cure. This is the DADS program under development now. 78% support requiring ignition interlock use by all drivers convicted of DWI, even first offenders. And Kendall talked a little bit about that already. 63% support lowering the legal BAC limit from 0.08 to 0.05. This is the NTSB's recommendation. And 4 in 5 drivers support a per se law for marijuana, yet 52% didn't even know if their state had one. And as I mentioned before, even though there's public support for it, we don't even know what a meaningful per se limit would be. So again, we clearly have a lot of work to do in this area, especially drug impaired driving. We know a lot about what works on alcohol impaired driving, but clearly, if we want to address that stubborn proportion of fatal crashes that involve at least one alcohol impaired driver, we need to be doing something differently. And so one of the things that I think that the highway safety community ought to consider doing, and one of the things I think the public health community ought to consider pursuing, is working together, all right? Because you all can pool resources, number one, and two, public health folks sort of come at problems in a very different way. Not necessarily better, just different, all right? And so there might be some utility there for all of us. If we can just sort of think outside the box, working with new people that maybe we don't always work with on highway safety issues. So state and local public health departments are required, in order to be eligible for state and federal funding, to conduct health needs assessment on an annual basis, every single year. They have to determine, look at the data and determine what are the health priorities in their territory, in their state. And if injury is one, then they have resources available to address injury. And as we all know in this room, highway safety or traffic crashes is a leading cause of unintentional injury in the country. So if state and local health departments have a charge and have an incentive to address this issue, obviously we all do, we ought to be working together in a way that we haven't historically worked together. I think NHTSA and CDC are doing some interesting things together, but I think at the state level, it's a little bit more fragmented. So I would encourage us all to think about new partners, think outside the box, and maybe consider some new approaches. So I'll stop there and actually take any questions if you have any. We got one in the back here.
I recently saw on the news that over the past 10 or 15 years that impaired driving by males has dropped 17%, but for females it has actually risen 38%.
Yeah, the Lindsay Lohan effect. The Lindsay Lohan effect. That's at least what they call it in California.
The workforce, and more women are now getting married at a later date, so they're doing the career thing, so they're going out to happy hour more and stuff. So their statistics has actually risen more than the men have.
Yeah,
do you have any information on that?
I mean, I know from a research standpoint, we don't really know why we're seeing a growing number of female drunk drivers. But obviously that's a trend that the research community is well aware of, and folks are looking into it and digging into that issue a little bit more. In California, our California club has dubbed it the Lindsay Lohan effect because, celebrities get involved in these, are arrested for drunk driving so frequently, and the public just turns a blind eye, especially in communities in California where folks are more used to it and desensitized to it.
That we've used for several years that shows that boys and young men's public intoxication, driving under the influence, so on and so forth. So alcohol-related violations are actually going down while the girls are going up. And in between like 17, 18, and 19, they increase sometimes as much as 100% each year in getting in trouble.
That's frightening.
It's frightening.
Have you figured out at all what the contributing factors to that trend are?
Well, we're looking at data that it's hard to tell what the, right? But we can make some extrapolations that as we have things that are more, that kind of show in the same time frame, that there are more palatable alcoholic beverages that are also more appealing and to those the younger folks and to young women.
Right.
And so there is some.
So you're identifying a high-risk group, though.
Yeah.
So now you're thinking
right.
like a public health person. I like it.
Well, I am a public health
There you
person.
go. Were there other questions in here? One in the back here. We'll come back to you.
I heard your comments about the per se limits about drugs being in a person's system for DWI purposes.
I'm sorry, repeat that last part.
I heard your comments about per se limits about drugs in a person's system. I mean, those of us in law enforcement, the difficulty we have is you pull somebody over who's high on meth, who's high on marijuana. We've got a legal limit for alcohol, but not for other drugs.
Right.
And the question is, what do you do with these people when the ability to come in and offer scientific evidence is sometimes limited? Since you're a physician, I'm curious to know, do you believe we should have per se limits for drugs in the state of Texas?
Well, first, I'm not a physician.
I thought you said epidemiologist.
That's not a physician.
Maybe I just misunderstand what an epidemiologist is.
Are you thinking of a dermatologist, a skin doctor?
All right.
I get that a lot. I don't make nearly as much as a dermatologist. I think there should be per se limits, without a doubt, but I think the challenge is we don't really understand enough through the data and the research to be able to determine what those per se limits should be for different classes or groups of drugs, marijuana being its own class. So, I mean, I appreciate the zero tolerance per se limits that exist in some states, and it's a tool law enforcement can use. But when it comes to convicting these people, it becomes very challenging. So that's where what I would consider our best frontline resource would be the DEC program and the DREs that program produces.
It seemed like, I'm sorry, I didn't mean to interrupt you. I had to ask one question to get to the second question. The second question is, does the science have to correspond with what we're seeing in people's blood in order for the public to choose to have a policy that advocates a per se limit? Like, I think your point is the science tells us we can't be sure if somebody's intoxicated or not. And again, I'm asking you because you're an epidemiologist who study these things. That's also true for .08. Some people are not necessarily intoxicated according to the loss of normal use of mental or physical faculties at .08. So why can't we just have a number for drugs?
Well, we can. That's a policy decision, though. That's not an evidence-based public policy decision. So absolutely, we can set one. In fact, Colorado and Washington State have set meaningless per se limits for marijuana.
Do you know what those numbers are by chance?
I think I might misspeak here. They're both 5. One is 5 nanograms per deciliter, and one is just 5. I'm not kidding. It's just 5. There are no units written into the code, so it's just 5 something, which is just as meaningful as 5 nanograms per deciliter, interestingly. So, I mean, I think that we can set a per se limit. That's just a policy decision. But if we want it to mean something, and your point about alcohol, while it's true individually, not everyone is producing the same level of crash risk as a driver at a certain concentration of alcohol in their blood, but at a population level, that relationship is pretty stable. But at a population level, those relationships aren't stable at all, even for one drug, because of things like chronic versus recreational use, the half-life of different drugs in different people's systems, depending on their fat versus muscle content. So there are a lot of factors that go into it, and the DREs in the room will know a lot better than I will what all of those factors are. There was a question back here.
Yes, I'm in driver's education, and one of the things that I've had a lot of people asking me, so I'm a continuing education chair of the association, and they've been asking for materials on teaching drug driving. We have just a ton of information on drinking and driving and underage prevention, but we have nothing on drug driving, and that's a question that I've been getting a lot. Where do we go to get materials that we can use to add to our alcohol awareness programs that we have?
Well, one, that sounds like an action item for this group, for the summit. Two, I know that some driver's education programs do have content, probably not enough, but some driver's ed programs do have content on drug-impaired driving. I know AAA's is one, but
Yeah,
we're looking at beefing that up ourselves. We have a lot of work to do. We have a lot of education internally to do.
thank
Do I
you.
have time for one more? Yeah, there was one right here.
We have a lot of cyclists getting killed by drunk drivers, and I'm very proud of. I live in Austin, and we have agencies that are really behind the movement of making drivers aware of their behavior. So one of the things that our mission is to change culture. But what I realized, I'm an engineer, so I realized that before we change culture, we have to change behaviorals. But before we change behaviorals, we have to change perception. And there's a lot of data, and I was going to ask you when you started speaking, what kind of data are we gathering every time we pull somebody as a drunk driver? I've never been pulled for a drunk driver, so I don't know if at the spot or at the police department they will ask those questions as a background and level of education and all that stuff. And maybe we can design and tailor education programs for those specific group of people.
Do you know
Not
about
all
like
of us.
screening and brief intervention type programs?
Yes.
Yeah. So those do exist in some states. And even in states where they don't exist at a statewide level, they exist in some emergency room departments and in some law enforcement departments. So that sounds like what you're describing is getting people who may benefit from substance abuse treatment into those programs.
And identifying those groups. I mean,
Right.
imagine that you can probably, like you said, anybody in the spectrum could be a drunk driver, but can we identify those groups and design a curriculum or program that's specific for those people, rather than one general program that serves all? I think we could take advantage of it. An educator identifying the learning style of those people.
Absolutely. A good example would be Hispanic drunk drivers.
Mm-hmm.
And even within the Hispanic community, different Hispanics from different countries
Exactly.
need programs that are designed for them and tailored to them. And even among Hispanics from a given country, those who live in Chicago versus Texas may need to be communicated in a very different way. And NHTSA actually has done a lot of research on how to develop a program like that for different groups within the Hispanic
Who's done a
community
lot of
in particular.
research?
NHTSA.
Okay, I'd like to see that. Thank you.
All right, thank you.